Hello everyone and welcome to our presentation. I am Genesis del Nogal and today I'm going to talk about an interesting case titled The Secret Guest. This is a 61-year-old male that came to the hospital complaining of fever and severe diffuse abdominal pain for 2 days. On review of system, he also referred fatigue, diarrhea, and weight loss for the past 2 years. On physical examination, the patient was normotensive but tachycardic and tachypneic. Morphy sign was positive and splenomegaly was noted. Lab work evidenced neutrophilic leukocytosis accompanied by low hemoglobin and hematocrit. Mean corpuscular volume was 64 and red cell distribution width was 17.6%. Also, as mentioned in Table 1, iron studies showed iron deficiency anemia. Abdominal ultrasound was positive for cholecystitis and the patient was admitted for management and laparoscopic cholecystectomy. Over his hospital course, fecal gall blood test was noted positive and a colonoscopy was performed. The mentioned study revealed multiple polyps at the cecum and the biopsy was positive for bilious adenoma. We consulted surgery and a right hemicolectomy was done with histopathology showing invasive adenocarcinoma. The patient was then referred to oncology and he was started on chemotherapy. During outpatient follow-up, he was found to have hemoglobin of 19.6, hematocrit of 56.2%, and MCV of 78. Further studies were done as mentioned in Table 1, and it was found that the patient was JAK2 negative, but erythropoietin level was low. Those findings, within the addition of leukocytosis, splenomegaly, and no other cause of secondary erythrocytosis were consistent with the diagnosis of primary polycythemia vera. The patient began weekly therapeutic phlebotomy until hematocrit was less than 45%. In summary, our case portrayed a unique situation as it is colon cancer and polycythemia vera that would not be diagnosed if we haven't studied the microcytic anemia. Iron deficiency anemia is a frequent diagnosis commonly associated with gastrointestinal bleeding. However, after surgical resection of the colon adenocarcinoma, our patient's hemoglobin abnormally increased. This made us consider other pathologies difficult to diagnose, such as polycythemia vera, and despite the patient was JAK2 negative, he met the criteria for diagnosis of polycythemia vera. Colon cancer nor chemotherapy is associated with polycythemia vera. This uncommon presentation of polycythemia vera was masked and somehow self-controlled by GI bleeding from eroded mucosal vessels at the colon cancer. Although the polycythemia vera was preventing the development of severe anemia, this could have delayed the diagnosis of colon cancer. Uncontrolled polycythemia vera has been associated with unfortunate operative outcomes such as hemorrhage and thrombosis, and therefore we recommend following the general screening guidelines to prevent disease progression like colon cancer, and also we advocate for preoperative assessment and abnormal counts should be optimized prior to surgery. For introductory information on polycythemia vera, please refer to the first section of the left upper portion of the e-poster. Thank you very much for listening.